message to that direction too, to this kind of stuff. Okay, thank you very much. Thank you. And we will have the last talk of the session, which is actually a little change in the program. So one talk will come up from another session, and this is going to be actually a clinical trial from Hungary. And Márk Félix Juhász will present this.
Thank you. So in the second presentation of this session, Professor Petersen mentioned that most clinical pancreatologists don't have or have little to no idea about basic research. On that note, here I am presenting a clinical research topic and the end of the basic science section for pancreatology. So today I was asked to talk about the protocol of the recent study by the Hungarian Pancreatic Study Group, the effect of dietary fat content on the recurrence of pancreatitis, or the F4 randomized control trial. And I'm trying to click with all my mic. Thank you. So the conceptualization of the study was mainly conducted by Peter, Andrea, and myself, but we also have a dedicated dietary development team, and a lot of other colleagues were, of course, also involved, for which we are very thankful. And to give you a short background, even though there have been a lot of developments in the last 2 decades in the in-hospital care of acute pancreatitis, the care doesn't, or at least shouldn't, stop at the end of the in-hospital period, because 10 to 30% of these patients will go on to develop recurrent episodes, and overall 10% of patients after an initial episode will eventually develop chronic pancreatitis. So what can we do to prevent this? We can tell the patient to stop drinking and stop smoking, which are the 2 most prevalent risk factors in chronic pancreatitis, and we can perform a cholecystectomy in biliary cases. But aside from that, there is not much we can do. Of course, there have been randomized control trials of cholecystectomy in idiopathic cases, but that has more to do with the etiological workup of patients. But on the other hand, low-fat diet is often recommended under clinical circumstances. The patients are told to keep a low-fat diet under the assumption that this will alleviate the tension on the pancreas and allow it to rest. So could it be the next intervention that could help prevent disease progression towards chronic pancreatitis, a debilitating disease with a higher risk for pancreatic cancer? It could be, but thus far it's a very empirical recommendation, not included in any of the guidelines, and evidence is scarce. Mostly retrospective analyses are available with conflicting evidence. Yes, and possible mechanism could be the increased triglyceride levels, which lead to the increased production of free fatty acids, which are believed to be pancreatotoxic. But it isn't tested thus far, and it could be. So our idea was to conduct a randomized control study, a trial in this matter, and either we get a new intervention that is a missing link. So in idiopathic pancreatitis, which we know is a risk factor for developing disease progression, an intervention that we could turn to, or we can discard an unnecessary reduction in fat consumption, which can be straining for the patients. So how we decided to do this is to randomize patients, roughly 400, to either a reduced fat arm in which the caloric content comes from 15% fat, or a standard healthy diet arm, which is basically the WHO recommendation with 30% fat content. We were also contemplating including a higher fat content diet, which I know sounds very ethically questionable, but we were toying with the idea of including a ketogenic diet arm. But after discussion with the participants, it seemed that they would likely not completely adhere, and if the fasting state isn't achieved, it could be more harm than benefit for the participants. So we stick with these 2 recommendations, the maximum that we can recommend, and 50% that seemed the minimum that would be feasible in a clinical context as well. And with these participants, we will complete the baseline survey. They will come visit us 5 times during a total follow-up of 2 years. And the patients we plan to include for 2 reasons is a bit restricted. One of the reasons is to have a higher recurrence rate possibly, so we have more events to see a reduction in. And the other is to focus it. So we are focusing on patients that have had at least 2 AP episodes in the last 2 years, and that the last one was idiopathic, and that they are at least 14 years old. because children in this matter might be even more important. I'm not saying, of course, that they are, their health is more important than adults, but in childhood, we know that the genetic alterations that are predisposing to disease progression can be present in 50% of the cases in ARP and 75% in chronic pancreatitis. So they are more prone to have risk factors that we can do nothing with. So an intervention such as this would be welcome. I will not go to detail on the exclusion criteria, but we will exclude patients with an uncontrolled diabetes mellitus, those with a BMI lower than 18.5, and those patients who regularly consume alcohol above a certain threshold. So enrollment can happen in two distinct ways. Patients can be invited to participate during the associated hospital. They can be identified by a medical database search. And if they fit this criteria, they will be determined for eligibility by collecting the medical history. Pancreatic and cardiovascular mortality, I'm sorry, I didn't hear. Newly diagnosed chronic pancreatitis, serum lipids, BMI, blood pressure, and we will also assess dietary adherence and quality of life and adverse events as well, which we are not expecting. Yes, they will be called back and these outcomes will be assessed at each visit. So months 3, 6, 12, 18, and 24 months, the closeout visit. And the dietary adherence will be based on the food frequency questionnaire and 3-day dietary recall results. Here you can see the study schedule, which basically highlights the same thing. After screening the participants at our location, we receive the intervention. We will assess baseline of all outcomes. We will also collect some additional information regarding comorbidities, socioeconomic status, and pancreatic history. And we will continue this until the closeout at 24 months. Dietary adherence is, of course, problematic. I don't think I have to go into detail on that. So we plan some additional measures to help the adherence of patients. One is the repeated interventions and frequent visits. We will gently motivate, or let's say remind participants that based on the FFQ 3-day recall, BMI, and blood lipid results, we will have a certain amount of an idea on how have they been adhering to the diets. Family members will also be invited to join the intervention if they wish. So this was also based on the participant prospect interview and Peter's idea actually that if a gentleman, let's say, is maybe less inclined to do the cooking at home, the wife can also attend if they wish. Thorough information on diets will be provided before enrollment so as to not have patients that we scare when we give them all the dietary material and they drop out before initiation. Similar intervention studies were reviewed for sample size calculation, and we will conduct a subgroup analysis of high adherence patients. And I would also like to point out that we will focus on the intention to treat analysis, because in a clinical situation, of course, if we recommend patients to keep the diet, we will also have problems with adherence. So in this regard, it's not, the matter is not those who keep the diet and those who keep the other diet, but those who were recommended diet A versus diet B, because that is what conceivable in a clinical scenario. Blinding, of course, in this case would be very problematic. So we are not advertising this study as blinded. Of course, study dietitians cannot be blinded. Doctors caring for the participants can. Outcome assessors will be, and statisticians handling the data. And of course, we cannot call this blinded from the viewpoint of the participants as well. But we plan that they will be informed of our aims, and of course, provided the necessary information on the study. They can ask questions, but the grouping that they received will not be explicit to them. Our aims and conclusions, well, we hope, what we think is that all participants will benefit, of course, because they will receive a calorie-adjusted diet that is either a healthy diet or one with a further fat reduction. And seeing the patient material, this is likely new and good for most of them. We hope to see an added reduction in pancreatitis recurrence and or mortality in the reduced fat group. But as I mentioned, if we do not see that, this is what we think is the limit of what is clinically conceivable. And in that case, we can discard probably this recommendation. And in case it proves beneficial, this will be the only non-preventive option in our examined population, non-alcoholic and non-biliary pancreatitis. And in Hungary, we already have 6 centers which joined and have the local ethical approval as well. The main study site will likely be the Semmelweis University Division of Pancreatic Diseases, and the main pediatric site, the Heimpal Hospital, also in Budapest. And we had Professor Wilshansky from Israel already join us with the local ethical approval, but of course, centers are welcome to join. And with that, I thank you for your attention. And if there are any questions, I will be glad to answer. Yes.
Food diaries are very difficult for patients to keep vigilant at. Every one of your patients has a smartphone with a camera on it, and you can take a picture of the meal and the computer will calculate the size and content of a meal. And that way you've got documentation. It's easy for the patient, and it's not embarrassing to take pictures of your food anymore.
Yes, I respond first if it's no problem. Yes, that's an excellent, and it's no shame indeed to take photos of your food. And that was one of our initial ideas as well. And the additional material I just flashed through, so you might not have seen, but it includes an application guide to such applications, which in Hungary is Yazio mainly. I don't know if you have the same, but it is not the main focus of the intervention. We had a preconception, which was more or less confirmed during the participant prospect interviews, that some participants in the age group might be less inclined to use smartphones, or if they do so, limit their use to telecommunication and not application use. So because the mean age is it is a bit problematic, I think, to be application first. And that is why we also planned without application scenario, but it will be included in the recommendations. Thank you.
So I've got a couple of questions. First one is, how do you define idiopathic?
Yes, in the initial workup, it will likely be clinician-based, which is problematic, of course, because we know that from idiopathic cases, roughly 30–40% can be due to biliary microlithases, which can be influenced. During the initial planning phase, we discussed with Peter that we will subject these patients to EUS and MRCP, which was a feasibility issue. Because of course, the effect, what you mean, is quite different. It can be quite different in biliary and non-biliary cases. In our centers, we do the etiological workup according to the IAP AP guidelines. So the patients receive either an EUS or an MRCP after the first idiopathic episode. And if not that, because I admit that that is sometimes missed, then the second definitely. but it can be a problematic scenario with outside centers, I agree.
And also, what is the number of recurrent attacks you estimated to do a sample size calculation?
Sample size calculation was again problematic because there are no similar studies. We also were involved in the testing of alcohol smoking intervention, the reappear study, for which Norbeck et al. Had a similar study on which we could base the sample size calculation. In this case, we based it on different fields that compared 15 and 30% fat diets and how those influenced and resulted in statistically significant changes in blood lipids, blood pressure, and mortality. And that was the basis of the sample size calculation.
We have an online question. Dr. Hussain?
Yeah, hi, can you hear me okay?
Yes.
Yes.
Great.
Okay, great. Hi, I'm sorry I'm not there physically, but I did have a question. And it is that great study, very interesting, always difficult to do dietary studies, as was mentioned by others. How will you control for micronutrient intake between the two groups? And I ask this because if you reduce the fat, then unless you compensate in some way, you might have reduced intake of fat-soluble vitamins, or you might have an increase in a certain amount. And so are you controlling for the other micronutrients that result in this between these two groups?
Yes, thank you. That's a very good question, because of course, if we reduce the fat intake, there might be a reduction in the intake of fat-soluble vitamins as well. And that is why we do not only include a food frequency questionnaire, and that is why we do not only include a 3-day dietary recall. We wanted to receive an as thorough evaluation, maybe possibly at the nuisance of the participants, that we can not only tell the macronutrient composition, but have an idea about the vitamin intake, and in case necessary, of course, turn to vitamin supplementation in those cases.
So just so I understood it, you're going to observationally look to see whether there are discrepancies and then compensate for them?
Yes, that is not part of the study setting per se, but the food frequency question and with the 3-day dietary recall, we will also have an idea about vitamin intake. We are not certain about the measurement yet. We are toying with the idea of measuring the vitamin levels, but we hope that based on the food frequency questionnaire and the dietary recall, we will have such an idea about the intake that we can intervene if necessary.
Just a quick comment, and do not answer because there's no time here. First of all, I've never seen a good study where people look at recurrence rate. It's very difficult to do, and I think it's impossible in the Hungarian setting. And the second comment is that there's an ample literature on that fat intake really goes to outcomes and not initiation. And you designed the study to study initiation of pancreatitis as a function of fat intake. So that's even conceptually flawed. So I'm not sure I would really, do not answer, remember?
Can I also?
I am sorry, Miklos, I must answer. You are completely wrong. Sorry to say. I mean, recurrent acute pancreatitis is one of the key points of the pancreatitis, because if you look at all the data and the development of chronic pancreatitis, this is one of the biggest endpoints. And if you can decrease the event rate of chronic pancreatitis, of acute recurrent pancreatitis, today there will be a huge amount of studies we will show you. Yes, we do. Okay.
Okay, one very last. This is why we are here.
Thank you. I think conceptually the study is very nice, but also I have my concerns about the sample size calculation. There's one, and secondly, in your primary outcome measure, you take a kind of combined endpoint with mortality. I would leave mortality out because you will never ever reach that. That's completely impossible. Even with severe predicted pancreatitis, we're not able to look at mortality. And by the way, if you die from pancreatitis, you had a recurrent attack. So I would leave it out to avoid any discussion.
Yes, thank you. I don't know if I can also respond to Miklós's comment, or he prohibited it, but
yes, please.
There are
Because
some studies, not the even lifestyle studies, that could observe significant changes with much more modest sample sizes than ours, which I agree is very high and will be likely hard to achieve. And the 5-year enrollment period that we set out, I hope will be enough, but hope is not a strategy, as Peter might say. So the study by Nordbeck et al., for example, compared annual versus 3-monthly alcohol cessation program, and they achieved, I think, a significant difference in recurrence with 120 patients or so. Yes, that's completely different, but
I think at this point we must stop. One sentence. Wait.
I mean, what you're suggesting to your patient is a healthy diet, if you want to say so. And in this situation, when a patient really adheres to a healthy diet, he will also stop drinking and smoking, because that is part of it, and that's your biggest bias.
But in this case,
yeah, well, but it's not about alcoholics. It's about the people like myself who gonna have a glass of wine or beer in the evening. If you adhere to a really healthy diet, you will start doing sports, stop smoking, because you can't take, you need more air for your sport, and then that's the biggest bias, and you have to find a way to correct for that. Otherwise, your results cannot be really attributed to fat intake.
I suggest to continue this actually. Those who don't want to go to the dancing, I mean, we will have an extra session.
Thank you for your comments.
Yeah. Yeah. And thank you so much for the talks and for the discussions. I mean, this was great.